All right. Good afternoon, everyone. My name is Mary Elena Mariquin. I'm the Community Engagement Manager here at Swope Health Services. And I'm really excited to be with you guys today. We're going to have our first series, our first Lunch and Learn series for our community. I'm joined by Dr. Jason Glenn. Dr. Glenn and I met a couple of months ago when he was talking to the community, the Health Equity Task Force in Wyandotte County. And we've since started talking and realized we have a lot of interest. And I'm very excited for you guys to hear his presentation today. Dr. Glenn's research includes health inequities, mass incarceration, the history of drug policy in the United States, and the history of subject research. Dr. Glenn hails from South LA, so California. He must be very cold in this cold weather. He received his bachelor's from Stanford University and his doctorate and master's degree from Harvard University. Dr. Glenn has worked with a couple of different research projects, as well as been the founder and director of Sobriety High, a nonprofit for people with substance abuse in the Galveston prisons. So, Dr. Glenn, we're very excited to have you and share with us your research on traditionally underserved communities. So, without any further ado, Dr. Glenn.
Thank you, Mary Elena. And I want to thank everybody at Swope Health Services for giving me this opportunity to share with you all this afternoon. I'm going to go ahead, share my screen, pull it up, and then put it in presentation mode so we can get started. So the title of my presentation, History of Abuse, Legacy of Mistrust, the History of Vaccination and Inequity Among Communities of Color. And it's important for me to present this history as honestly, as brutally honestly as possible, so we can distinguish between what are legitimate concerns that we should have about vaccines versus the illegitimate concerns that folks might have about vaccines. And how do we make informed decisions about the new corona vaccine being offered to us? So, I want to start off just by indicating that we suffer, communities of color particularly suffer from a lethal mix of misinformation and mistrust. That mistrust is often grounded in historical deeds of abuse. And I'm going to talk about some of those historical deeds of abuse. But sometimes it's grounded in a lot of misinformation. And I want to help give us the tools to analyze the misinformation and disaggregate the misinformation from what's true in order to help us make better informed decisions. So first, I want to differentiate between some key terms that I'll cover in the history. The first is the term variolation, which serves as the origins of the concept of vaccination. And I'll talk about this more in a minute, but it's the act or practice of actually extracting some pus from the sores that grew on the body of people who were suffering from smallpox, and or gathering the scabs of smallpox infections and letting them dry and turning them into a dust powder, and then injecting them, either that pus into an abrasion on the skin or that dust into the abrasion of the skin on a healthy person as a way to inoculate them against future smallpox infections. Inoculation, which is also a term that you hear used interchangeably with vaccination, is any method, including variolation, but also including vaccination, of inducing an immune response to protect against future disease. And then vaccination is the act of introducing a vaccine into the body in order to produce an immune response. And we see all those terms often used interchangeably also with immunization. So it's important that I just wanted to sort of clarify what the differences are as we get into the history. The next thing I really want to emphasize is that the concept and the technology behind the idea of vaccinating is really something that comes from the old world and places of people of color. Origins of early variolations for smallpox, we see in the historical record in places like China, in India, in East Africa and Ethiopia, but also in West Africa, and then also in Turkey. And it's the reports from both Africa and Turkey about the widespread use previous to the 1700s that Europeans first learned that the idea of the practice and started experimenting with it themselves. So once again, this is a concept, technological innovation that goes back to many old world populations. If we wanted to take a brief look at a timeline for our various uses of vaccination practices, smallpox variolation existed before the 1700s. We see the earliest historical records of it all the way back to 900, the year 900 or the 9th century, all the way back in China. We are unsure how far back it goes in the other contexts that I just discussed. But it wasn't until 1796 that in Western European and American context, we first started getting use of a smallpox vaccination. And I'll talk more about that in a minute. And what you'll see is there's a huge 100-year gap between the introduction of a smallpox vaccination and the typhoid vaccine that happens in 1896. And the reason was, one is because the method involved in variolation and early vaccines was very dangerous. It involved taking some either active virus particles or infection particles from other people who were suffering from the disease and introducing it into a healthy person in order to stimulate an immune response, but hopefully do so in a way that wasn't as lethal as if the person had caught the disease on their own. And so many early attempts at trying to replicate smallpox vaccines failed miserably. And it wasn't until until Westerners gain a much better understanding of both bacteria and viruses in the late 19th century and early 20th century that they became much more accomplished in developing vaccines. So we can see the march toward further vaccine development. After typhoid vaccine, we get tuberculosis in 1921, diphtheria in 1923, whooping cough in the 1930s, tetanus vaccine, 1938, the polio vaccine in 1955, which was really a game changer, and then measles, mumps vaccines, 1963 and 1967. We haven't had as prolific vaccine development as we did during those early years, because up until recently, that traditional concept and way of developing a vaccine of either giving somebody part of the virus that was infecting them remained very dangerous and was accomplished with very mixed results. So in the stories and the legacy that I'm about to lay out for you, I want to make one thing clear in terms of how we generally understand the history of Western medicine and Western medicine's research practices throughout the 19th century, early 20th century, but also as far back as the 18th. And that is that until the enactment of new regulations during the civil rights era, you know, which roughly 40 years ago. Throughout the history of both anatomical and biomedical research, the vast majority of persons who were chosen to be research subjects were those who were confined and or institutionalized. And these were people in prisons, people in asylums, mental hospitals, orphanages, and sometimes those held as slaves until the end of slavery. The institutionalized populations were often mentally ill, they were terminally ill, they were orphans, but most were prisoners. This included an extensive use of Black persons, particularly throughout the American South. Black bodies in particular, both alive and dead, were used for experimentation and education throughout the 19th century in medical schools, primarily those throughout the South. Medical schools would compete against each other and for new students by advertising their access to what they call clinical material. And that was a euphemism for cadavers. Black bodies found themselves on the dissecting tables in medical schools, in the operating amphitheaters, in classroom demonstrations, and in laboratories. There was a particularly huge demand for Black cadavers, which were usually either executed prisoners or those that were granted by the state, or those stolen from graves. So it was state policy throughout the United States that people executed would have their bodies donated to medical schools for use of anatomy teaching and demonstrations. And there was also extensive grave robbing that took place in the South, particularly in Black cemeteries. And this was, of course, because people felt that those lives had less value. This, if you go throughout the archives of many medical schools throughout the country, you will see many images that look like this. And this became a sort of rite of passage of new medical schools or students at medical school, new students at medical schools as they took anatomy instruction in their first years. And what you notice about this, one, in these photographs, you can definitely see the skin color of the cadavers. And in this one, you can see that this cadaver was a Black person. And then you also, they were often posed with the porters that were hired to clean up the anatomy labs after all the dissections had taken place. And so it was very common for students to pose with their cadavers in various arrays, and then have these images mounted onto postcards and send them to their families. This is one of the ways that we know how extensive the use of Black bodies were. In getting to expressly the experiments that were used to test the idea of variolation and then vaccine development, it also starts with smallpox testing. And some of that took place here in the US took place in Boston in the 1700s. Up there, Dr. Zabdiel Boylston conducted some of the early studies in 1721, and he was testing the concept of smallpox inoculations. Boylston is recognized for a lot of the firsts in American medicine. He performed the first surgical operation by an American doctor, did the first removal of gallbladder stones by an American doctor in 1710, first removal of a breast tumor in 1718. And he was also the first to try the concept of smallpox variolation in North America. The way that they learned about it, Boylston learned of the concept from Minister Cotton Mather, and that may be a familiar name to many of you, but who was told by one of his slaves of the widespread practice of variolation throughout West Africa, where mothers would take a little bit of the pus from others who had suffered from smallpox. make an abrasion on their baby's skin, and then rub some of that pus into the abrasion as a way to give them a kind of attenuated dose of the virus to produce an immune response. Boylston, in testing the procedure here, used 250 Black persons, and it was only after seeing that the process was successful with those 250 Black persons did he try the method on his own son and then publish about it. This was very similar to what Thomas Jefferson would do nearly 90 years later. Jefferson wanted to test Edward Jenner's smallpox vaccine, which was derived from cowpox, versus traditional variolation methods. So Edward Jenner, many of you know, or the way that this history is commonly taught, is sort of the pioneer of vaccination techniques because he was the one to introduce smallpox vaccination to Europe and the United States. And the way he did so, folks recognized that cowpox seemed to be very similar to smallpox, and that if they took some of the pus from cowpox and injected that into persons, that had less chance of causing a full smallpox outbreak, but still could produce an immune response. Thomas Jefferson wanted to test the accuracy of Jenner's methods. So in 1801, Jefferson obtained a little over 200 doses of the cowpox-based vaccine from doctors in Boston. And then what he did, just like Boylston, he tested the vaccine on 200 slaves from both his plantation and from the plantations of some of his neighbors. And also for dramatic demonstration to his scientific peers, Jefferson ordered a vaccinated slave to be injected with live smallpox pus from an active sufferer. And it was then after a few days where that vaccinated slave did not develop the disease that Jefferson decided to vaccinate the rest of his family there at Monticello. There were even some doctors early on in the process, before fully understanding the concept of vaccination in a biological sense, who thought they might also test whether or not the smallpox vaccine would work for vaccinating sufferers of typhoid. And so Dr. Robert Jennings wondered if Edward Jenner's smallpox vaccine might also work to thwart the spread of a typhoid epidemic that was taking place in Virginia in 1832. He vaccinated some 30 slaves and some free Blacks who had family members who were actively suffering from typhoid fever, and then withheld the vaccine from other family members as a control to see whether or not if the family members who did not have the vaccine would develop typhoid fever as opposed to those who did have the vaccine. And amazingly, Jennings then lied about his results to cover up the recklessness of what he had done, insisting that the smallpox vaccine worked to protect vaccinated slaves from catching typhoid fever. And we know that he had to have lied because we know now very definitively that smallpox and typhoid are not related at all, and that the immune response to the smallpox vaccine would in no way protect someone from catching typhoid fever. As we worked our way further into the 20th century, I want to bring up, a lot of people know about the US Public Health Service syphilis study in Tuskegee. Not as many people know about the US Public Health Service syphilis study in Guatemala. And during that time, US researchers working for the US Public Health Service intentionally infected 1,700 Guatemalan prisoners and mental institution patients with syphilis and other STDs to test the efficacy of penicillin not only as a treatment, but as a prophylactic, like a vaccine. The idea was whether or not if folks were given if folks were given penicillin like a vaccine, whether or not it would protect them from actually developing syphilis. This was very important for the United States. Of course, this was during World War II. And during the wars, as had been witnessed during World War I, because US soldiers would frequent not only prostitutes, but also with any war and with any group of soldiers, we know that rape frequently occurs in the population where the soldiers end up, that a lot of soldiers were constantly sidelined due to STDs. What researchers did in this study was that they hired prostitutes there in Guatemala and purposefully infected them with syphilis and forced them to have sex with prisoners and patients in mental institutions. And then if a syphilitic infection did not occur naturally, they gave the men and the women abrasions on their genitalia and forced them to have sex again. And if that still did not work, the men were given syphilis by spinal injection. The study was conducted in 1946 through 1948, and it was conducted by many of the same personnel who had conducted the Tuskegee study. And why that is important is because the Tuskegee syphilis study was started in the 1930s, in 1932, to be specific, and lasted until 1972. So long after this study was conducted, right? Co-sponsored by not only the Public Health Service, but also by the NIH and the Pan American Health Sanitary Bureau, which is now the Pan American Health Organization, and also the Guatemalan government. The US got the Guatemalan government to agree to it in exchange for saying that they would provide penicillin to them to deliver as public health measure in the aftermath of the trial. And that's often how researchers from the US have gotten foreign governments to agree to some of the studies that have taken place outside of US soil. The study ended in 1948 when the researchers could conclude definitively that penicillin was a cure for syphilis. They also concluded that it did not work well as a prophylactic or as a vaccine, but it did work very well as a cure. And again, this is important because even after the conclusion of this study, they continued the Tuskegee study, letting the men, the nearly 400 men that were in that study, go untreated for their syphilis for for a few more decades. What's also important to note here is that many cases of gonorrhea and syphilis were left untreated after the conclusion of the trial. We know at least 83 of the subjects died due to unspecified complications of the disease. And these same PIs who worked on the Guatemalan study and who knew that penicillin was an effective cure for syphilis were also the ones that insisted that the subjects in Tuskegee not be treated. So, that's sort of the, a quick and dirty of the longer history of testing and experimentation and the disparities that existed in testing and experimentation before we saw reform in the 1970s. That reform didn't mean that all of a sudden everything was all hunky-dory and American researchers and European researchers had completely cleaned up their act. What often happened instead is that instead of these same egregious practices taking place on US soil, researchers went to more foreign countries to conduct their studies. And one of the more recent ones was the Edmonston-Zagreb measles vaccine testing that took place in the 1980s. There, US researchers conducted studies comparing the newer Edmonston-Zagreb measles vaccine and comparing it at a much higher dose than had been previously used with the standard of care at the time, which was the Schwartz measles vaccine. And they did so in thousands of young infants in several poor countries. This is including Guinea-Bissau, Senegal, Haiti, Gambia, Togo, and the Philippines. Many of the infants died in those trials, but because the causes of these deaths were also common causes of child mortality in poor countries, things like respiratory infections, diarrhea, and dehydration, the researchers could not adequately determine if the experimental high dose of the Edmonston-Zagreb vaccine was to blame. And this sort of, brings forth the problems in when we go testing in many resource poor countries, because it becomes harder to determine whether or not, if we see higher mortality rates, if that is due to the vaccine or if it's due to other causes that may also be systemic in nature, may also be caused by racist economic arrangements, but may not necessarily be caused by the vaccine itself. And this is important. And one of the reasons that they tested in poor countries was how difficult it would have been to secure approval in the US at that point, once our research apparatuses had been overhauled to have much, much stronger protections for any human subjects in the US context. I also want to point out here that the major issues that communities of color had to fear was the act of being used as guinea pigs, not that something nefarious was necessarily inserted into the vaccine. So the vaccines, the researchers in the vaccines actually had good faith intentions in trying to find cures for very problematic diseases. But some of the rumors and misinformation about vaccines going around is that, that there are government agents who are trying to insert various nefarious or harmful things into vaccines on purpose, right? And I want to make that clear that using poor people of color as guinea pigs for treatments that, for all other intents and purposes, have good faith intents to try to find cures for disease, while still racist and still incredibly exploitative and abusive, is fundamentally different from trying to use vaccines as a way to poison or somehow do something nefarious to poor people of color. And so it's important to make that distinction when we talk about the current coronavirus vaccine that is going around. So first and foremost, understanding the corona vaccine is really about a love story. And it's a love story about these two folks who were the founders of BioNTech. They are or were Turkish immigrants to Germany who met in medical school and met with the idea and the overarching purpose to find new ways to cure cancer. One of the ways they did this is because of how limited radiation and chemotherapy treatments often are, right? That in essence, if one of the ways, an easy way to understand cancer is sort of the runaway growth of malignant cells in the body. And that runaway growth of malignant cells in the body is one where they begin eating up all the rest of the body's resources. Normally, what our immune systems are able to do is find cells like that and eliminate them. But with cancer, for some reason, our immune systems don't eliminate cancerous cells, and they continue to replicate in our bodies. What these researchers wanted to do was find a way to train our immune systems to better eliminate cancer cells the same way that vaccines train our immune systems to recognize threats like viruses or bacteria that can cause various forms of disease. And so they started experimenting with messenger RNA technology to see if they could find a way to train immune systems. What messenger RNA, a brief, sort of quick and dirty, is messenger RNA, very different from DNA, which is the blueprint for all the cells and different types of cells in our body. Messenger RNA are blueprints for creating proteins, and proteins are kind of the building blocks of muscle mass in the body and other critical working parts of our body, right? What the researchers at BioNTech wanted to figure out is, could they use messenger RNA to create a protein that on the outside looks like a virus, as a way of teaching the body and priming the immune system to respond to that virus. The difference being, a normal virus, if we, were to slice it open, it looks something like this, right? You have what are called the spike proteins on the outside, but in the inside, you have your further messenger RNA that teaches the virus to replicate when it enters different cells. The new messenger RNA vaccine technology would create a protein, again, that looks like a virus on the outside, but does not have the messenger RNA on the inside. And therefore, it would be fundamentally different from all previously developed vaccines. Remember, as we went over the history of vaccination, right, the idea is that you give someone either a part of a virus, a live virus, or it could be even a dead virus. And that was a way of teaching the immune system to respond to that virus. However, there was also a chance that you could catch the disease to which you were being immunized from. Usually, and it was hoped that you would catch a form of the disease, if you caught one at all, that was very, very mild in its symptoms, and that you would survive, right? The messenger RNA way of producing proteins that look like a virus on the outside, but don't have the messenger RNA on the inside that tells the virus to continue to replicate in the body, presents a new kind of vaccine where you don't actually have any of the danger of catching the disease, because the protein that looks like a virus on the outside cannot actually replicate in your body, right? There's no virus material inside of it. And that's a game changer. It is a huge game changer because it improves the safety and efficacy of this particular type of vaccine. A lot of folks wondering how this could have been developed so quickly. But if I go back to our pioneers in this story, they started this experimentation over 30 years ago. So this kind of vaccine has been 30 years in the making. And folks have been looking at coronaviruses and their structure since the SARS outbreak in the early 2000s. And so because of all that research, it was fairly quick that folks were able to map what the coronavirus looked like. And therefore, folks here at BioNTech realized that they could potentially program a new vaccine that could produce a protein that looked like the coronavirus on the outside. Also, what's important to note is that there were over 43,000 people who participated in the phase 3 testing of the BioNTech vaccine. And that is the vaccine that is the basis for both the Pfizer and Moderna, or that is the technology that is the basis for the both Pfizer and Moderna vaccines that are currently being distributed in the United States. What's also important to note is that there was equitable representation from all races in the development of these vaccines. People of color were not singled out to be used as guinea pigs, nor were prisoners, nor were any of the other institutionalized populations that I spoke of at the top of this presentation. So there was equitable distribution in who were going to be the test subjects, and out of those 43,000 test subjects, we found that this vaccine had a 95% efficacy at preventing very severe forms of the disease. And so that's very important and why I want to point it out to folks. And also, I want to share a little of the recent data that is also the reason for me being here and speaking with you all today. So here locally, I have been part of sort of the planning in Wyandotte County for equitable vaccine distribution. And like many counties, we set up a web portal where people go and register to express their interest in being vaccinated. And a couple days ago, we had a look at the data from our first 26,000 responses that we've received. And this is kind of what it looks like. I want to highlight, the response rate from African Americans and from our Latinx brothers and sisters, and in comparison to the percentage of white people who have signed up. And why we know this is out of whack is because in Wyandotte County, we know that it is roughly 20% African American, and also probably roughly 20% Latinx residents in those counties. And so what we're facing right now is because of all the mistrust and the misinformation, and maybe because the word isn't getting out right, that a lot of people from these communities aren't signing up in the same numbers as people from white communities are. And folks like myself are finding that really alarming because it's people of color that are disproportionately dying from coronavirus. And the folks who are involved in planning at the county level are really trying to make sure that that disparity doesn't continue. And that's why we've developed a vulnerability index for targeting those who are most at risk, not just those who are most at risk from actually being exposed to the coronavirus, but targeting those who are most at risk of dying if they catch the disease. And that's why we're out here trying to beat the drums and trying to give good information about what are some of the real dangers that people face and being able to separate that from misinformation. Like I said at the top of this presentation, it's the combination of both the mistrust and misinformation that in this instance is really working against our populations. And we want to make sure that that doesn't continue. There are many reasons grounded in histories and legacies of misdeed, of abuse, and of exploitation that our communities have suffered from, which is why so many people have a mistrust of the medical profession. But there's also so much misinformation and myths about vaccines and what they're doing, whether or not they're microchipped, whether or not they cause autism, or whether or not they cause other diseases. And all of that is misinformation and is not grounded in actual science. And so that's why it's so important that we try to understand what are the real concerns that we have. And the biggest concern that we have historically has been that poor people of color have often been used as the guinea pigs to test new vaccines. This wasn't the case with the coronavirus vaccine, which is a good thing. And in addition to that, what we know is that so far in the US, we've administered over 30 million doses of vaccine. And because the disparity has been such that the vast majority of folks receiving the vaccine have been white, we are continuing to monitor everybody who receives a vaccine. And we know that a lot of the fears that people have are not coming to fruition. So if people were fearful and they wanted to see how others are doing and how others are faring who've received the vaccine, we have all of that data now from over 30 million people here in the US, and then millions more over in Europe who have received the vaccine, and we're not seeing any of the issues that people cite when they express their fears of being vaccinated. So with that, I will conclude. If anybody has any questions about this presentation or about this history and would like to talk more, I am happy to take your questions here on this Zoom meeting. And then if you would like to contact me later and you have questions about it, feel free to do so. There's my email address there on the screen. And with that, I will stop sharing and go back to our regular screen and see if we have any questions.
Thank you so much, Dr. Glenn. It doesn't look that we have any questions, although people are very grateful for your presentation. Feel free to put those questions in the chat should you have any. I actually do have one question, Dr. Glenn. You said that we need to arm ourselves with good information. Where do you suggest that we can find that, quote, good information? What is a good source that's accessible for us, you know, the everyday person who doesn't understand all of that tough terminology?
Very good. And thanks for that question. You know, part of the reason why we suffer from so much misinformation is because increasingly we rely solely on our social media accounts to get adequate information. And relying on social media companies have been very slow to respond to all the misinformation that people post. And the reason that they've been slow to respond is because it goes against their business model. Their business model is to increase traffic on their platforms. And oftentimes, the most outrageous misinformation generates the most traffic. So you see that those companies have a vested interest almost in not curtailing the misinformation. What you want to do is you want to go to sources that have a little more skin in the game and you know would be in trouble if they were directly lying to you. And, you know, I am, you know, the first to point out that a lot of our mainstream media sources also have histories of, you know, sort of towing the official line and not necessarily being upfront about the histories and legacies of abuse and exploitation that we faced. However, we can find very good information about coronavirus and the vaccines, first and foremost on the CDC's website. And then, you know, one of my most trusted news outlets is the independent news outlet Democracy Now! At democracynow.org. They are independent. They are not a big corporation news organization. So if you were looking for independent news, that would be a good source. But your New York Times, things like that. Even if you wanted to go for news sources that may be based outside the US, The Guardian is a great source, right? You know, some of those mainstream news organizations that their editors would face a lot of heat if they were to print very bad misinformation, right? So just shop around, right? And then also, if you want to go to the more scientific press, right? You can also look at the scientific articles. Oftentimes the scientific articles, if you go through the bulk of the article, it can be, sort of very hard to read, but the summaries in the abstracts in the very top can really help you out. And so you can find those on PubMed. PubMed is a publicly searchable database, and you can bring up all the articles of the research that has been done. Also on the CDC's website, or also on the FDA's website, I'm sorry, if you wanted to see the actual data that Moderna and Pfizer submitted to the federal government that shows you what happened with the over 40,000 people who were in those studies, that is publicly available as well. And it's actually written in a way that's more accessible than your typical scientific article, even though those documents are long, probably about 40 something pages. However, you can look and see for yourself exactly how people fared in those phase 3 trials.
Thank you so much. I think that I wrote those down, and I'll make sure that we put those available for our associates as well as on our social media pages. I have a couple of questions that have come in. One of the questions is, has anyone presented with Parsonage-Turner syndrome that has been vaccinated or contracted this as a result of the vaccination?
There has not.
Okay,
yeah.
That was very, very simple.
So, one of the things, and this is important too, right? So a lot of the misinformation that we hear about vaccines, there will be someone that says, I heard that so-and-so got the vaccine, and a couple weeks later, they developed this illness, or a couple weeks later, they died. And one of the reasons that we look at large trials with thousands upon thousands of people enrolled is so we can differentiate, right, the people who may develop other diseases as part of just, their natural living, or people who may die of other natural causes. And one of the things we do in those studies is we have a control group, right? The control group who doesn't get the vaccine. One of the things that we heard often reported that people took away, it wasn't misinformation, but it was misused information or misunderstood information, was that among the 43,000 people in the Pfizer trial, that 5 people died. It's true, 5 people did die in that trial, but when we look at the control group versus the vaccinated group, we found that those deaths were overwhelmingly likely due to natural causes, that anytime you take 43,000 people, especially some who are elderly, and follow them for a period of 8 months, there's a likelihood that a small number of them would die of some other natural cause within that period of time. And so we look at how the control group did as compared to the vaccinated group. And if the people who had died had only died in the vaccinated group, then that would have been cause for alarm. It's the same way, the same concept with, people who may develop other illnesses, right? That we look at the millions of people who've been vaccinated thus far, right? So we take a cross section of 30 million Americans, many of whom at this point are very elderly, and we say, look at how many may have developed any other illness and may have died, who have been vaccinated compared to those who have not been vaccinated. And we know that normally when you have a cross section of the population, there's a certain percentage of that age who are going to die and who may develop other illnesses. And it's whether or not there's a higher percentage in the vaccination group compared to the control group, that's when we know we have a problem. And that's the difference between the anecdotal examples of so-and-so got the vaccine and then X happened to them, as opposed to looking at the numbers as a whole.
Thank you. And there's a follow-up question I think that I misunderstood. In other words, since I have this disease, can I take this vaccination? So I think the question is, can this person or the person who has this disease receive any of the vaccinations that we are talking about today?
Generally, yes. The vaccine hasn't been shown to be, detrimental or harmful to people's suffering from other diseases. Now, with a caveat, I say you should always discuss with your own personal doctor. And then a further caveat to say people with compromised immune systems may experience the side effects of this vaccine a little more prominently. And what the side effects are, because this vaccine fools your body into thinking that it's fighting a virus, we see that, and this is more common with the second dose, that some people experience 24 hours of things like fever, chills, maybe headache, right? And so people with compromised immune systems may experience more or more severe form of that, but it's typically very brief. But as always, talk to your own healthcare provider about your specific condition if you have questions like that.
Awesome. We have two more questions here, and this one comes from one of our directors here who's worked very closely with our vaccine and our COVID team. How do other vaccines, such as childhood vaccines, look among communities of color? Do they have a lower compliance rate than other populations?
Generally, no. And the reason for that, in countries where those vaccines are mandated, generally no, right? And the reason for that is because in order to get your child enrolled in school, you have to get your child vaccinated, right? In some poor countries, in resource poor countries, where there may not be enough vaccine to go around or it may not be mandated, then we do see that those disparities pan out among the lines of the populations who were historically discriminated against in those countries. Not all countries have lines of oppression and discrimination that are along race. In some countries, it's more along religion, clan, and language group. However, where any country you go, your population that's on the bottom, those are the people who suffer most heavily from almost any disease category we want to look into. But here in the US, vaccine disparity for those childhood vaccinations is very, very low because it is mandatory that children have to have those vaccines in order to go into school.
Perfect. And then the last question here, please feel free. We have 5 more minutes. If anyone has any questions, please feel free to put those in the question and answer box. And this person is speaking about the Tuskegee effect to people of color. So I guess kind of that conversation that we've had about the syphilis trials, and you explained in depth the study of syphilis in Guatemala, which I was completely unaware of. So I guess maybe just talk a little bit about that and how that has residual effect in communities of color.
It has extremely residual effects. And, I haven't been immune to them myself. My own father died of heart disease when he was 49 years old, and I was 13 years old. His doctors knew that he had heart disease and were recommending an operation to try to repair some of the damage to his cardiovascular system. And he refused because he grew up born in 1936 with the idea that, one couldn't trust medical doctors and didn't want anybody performing surgery on him for that reason. And, and whether or not it's the specific study of just Tuskegee, really Tuskegee is only the tip of the iceberg in terms of how much exploitative and abusive research took place using primarily both prisoners and poor people of color. And because of that, we inherit generation after generation that wisdom from our elders that say, medical doctors are not to be trusted. One of the differences between, what was the reality of the biomedical profession during my father's generation when he was growing up and during my generation is that when legal discrimination was the law of the land, the majority of the people who worked in the biomedical profession were white.
Mm-hmm.
And that is no longer the case. When we look at all the different, the ranges of people in the medical profession, it is a global profession. And there are persons from various backgrounds from all over the world, various racial, ethnic, and religious backgrounds from all over the world, including a lot more people of color, and not just, as physicians, but in all the different occupations all the way down. Now, of course, the higher paid occupations still have a disproportionate number of white folks in them compared to the lowest paid occupations. So we see a lot more people of color who are nurses, who are nursing assistants, phlebotomists, et cetera, right? But my point is, right, that all these people did not go into medicine with the intent of oppressing people of color like them. They went into medicine with the intent of trying to right a lot of the historical wrongs that our communities have been subject to. And that is important for realizing, that the histories of abuse and exploitation that we've inherited, we cannot blanketly assume that all of that same racism is always at play at every single encounter that we have with folks in the medical profession. There are still concerns in terms of the health inequities that we see in our society. We still see that folks of color are often not listened to the same way when they make complaints to their doctors about what's bothering them or about something not being right, and that we see disparate treatment in a clinical setting. We're diagnosed later with lethal diseases, and we're not always given the same treatments. So those concerns are still exist and they persist, but we cannot assume that the overall the biomedical industry has at its heart the intent to oppress people of color because it is a much different field now, and it is occupied by so many more people of color themselves who have gone into it with the express purpose of trying to right those historical wrongs.
Thank you. I think that we can all kind of identify with that and the desire to, one, really help our community. I think that our associates are very much mirror the community that we serve. So I think that we have especially a duty here to protect ourselves so we can further protect our community. A couple of questions and a couple of housekeeping items. Yes, this has been recorded. It is also on Facebook Live. I will try my due diligence to make sure that it gets on the e-portal for our associates, as well as on our Facebook page. It will be available to replay after this recording is done. We have one final question before we leave. Dr. Glenn, I want to thank you so much for your time. Thank you for your insight. I do appreciate your time. Associates, thank you so much for joining us and taking time out of your very busy schedules to have this lunch hour with us. And those community partners, especially I've seen some people from the KU Men's Center, as well as Diversity, Equity, Inclusion Office, as well as some of our folks at Comeback KC. Thank you so much for your continued support and partnership. We would not be able to do these awesome things without your support. So thank you very much. One final question. Hello, do you think the COVID vaccine will become mandatory?
No, not right now. There are no plans to make it mandatory. And one of the reasons that there are no plans to make it mandatory is because we specifically don't want to play into the fears that many people have, that this vaccine may do something harmful to you, right? Or ideas about, government conspiracies. So it is not mandatory. It is completely voluntary. And, you know, but that's also, meaning that if our communities who have more mistrust, we are suffering because we're not getting it in the same numbers. And so that means more of us are continuing to die. So it's our choice.
Yeah. Well, thank you. That sad note, but really thank you so much for helping us understand, one, the history in our communities, two, what we can do to learn more about the vaccines that are available to us, Moderna and Pfizer. I know here we received the Moderna vaccine and all of our associates had the opportunity to partake in that, as well as those places where we can find that really good information that will help us make informed decisions for ourselves and our patients. Dr. Glenn, thank you so much.
Pleasure was mine.
We look forward to having you again.
All right.
Bye. Take care.